In this video, we will discuss the surgical technique for the treatment of retinal detachment using a segmental buckle. In this case, shared by Dr. Jamil Poletti from Lima, Peru, a young patient presented with a macula-off retinal detachment, with attached vitreous, and a large inferior temporal retinal break. The chosen treatment was a circumferential segmental buckle using a silicone sponge. The surgeon begins the procedure by performing a 180-degree inferior peritomy, followed by isolation of the inferior and lateral rectus muscles. When placing a segmental buckle, the intrascleral suture arms are positioned parallel to the limbus. The anterior suture bite is placed just anterior to the posterior edge of the vitreous base, approximately 2 to 3 mm posterior to an imaginary line connecting the rectus muscle insertions. A silicone sponge with sufficient width to support both the anterior and posterior edges of the retinal break was selected. The surgeon also uses nylon sutures to secure the edges of the sponge to the sclera. This technique helps reduce the long-term risk of segment exposure. Next, the surgeon uses a chandelier light for internal visualization to confirm the proper sponge positioning. Then, he decides to perform direct subretinal fluid drainage using a needle. Consequently, a mild subretinal hemorrhage was observed following the drainage. This complication could have been prevented with the use of cautery after dissecting the scleral edges and exposing the underlying uveal tissue, prior to proceeding with the drainage. Cryotherapy was then applied to the margins and around the retinal break. Ideally, cryotherapy should be avoided directly over areas of bare RPE to reduce dispersion and minimize the risk of PVR. After conjunctival closure, an air injection was performed to restore intraocular pressure and assist with retinal reattachment.